Okay, so all right, so this is the outline of this talk. This is a talk I gave like some time ago to some of the nurses and the staff at Joe DiMaggio. So some of the stuff may be very basic, some of it may not, but I think it will help you really hone in on what NAVA is supposed to do and how to make the most of it. So the first thing I'd like to start off is NAVA stands for Neurally Adjusted Ventilatory Assist. And I think that's very important that we keep track of the fact that this is a way to assist respiration, and this is not like other ventilators, and we'll see a little bit about what this means. So the reason NAVA was designed was to address many of the challenges that we face with neonatal ventilation, most notably rapid respiratory rates, small tidal volumes, periodic breathing pattern, short inspiratory time, and the fact that we're ventilating most of our newborns with uncuffed ET tubes, dealing with a lot of air leaks. The designer of the NAVA technology thought that they could solve it through this new mode of ventilation. So the premise of it is that you have your diaphragm and you have nerve conductions through the left and right phrenic nerve, and they're basically innervating your diaphragm that contracts and relaxes during respiration, right? So during inhalation, your diaphragm contracts and moves all the way down. And then during exhalation, it relaxes and moves all the way up. I know this is very basic, but the reason I'm bringing this up is that the diaphragm never fully relaxes, right? I mean, that's something that's important for us to remember, especially when we talk about EDI. So the rib cage, the lungs really prevent the diaphragm from contracting all the way. And there's always a little bit of tonic activity, even at the end of exhalation. So that's something to keep in mind. So what we're looking at specifically is in the diaphragmatic activity is the electrical excitation of the diaphragm, right? Which usually starts off in the respiratory signals in the brainstem that are traveling down the phrenic nerve. We talked about the movement of breathing, and the electromyography of the diaphragm is what is being referred to as the EDI, right? And that's a term that's going to come up over and over again when it comes to NAVA ventilation. All right, so we don't really need to talk about that. That's pretty much pathophysiology of breathing. But the bottom line is that NAVA leverages the electrical activity of the diaphragm to provide synchronized ventilation. And that's another very important feature of NAVA that we'll get into in a second. So let's start with some of the tools that we have, right? So we have the NAVA catheter, and this is what it looks like. You have this outlet here that basically is connecting to your wire, and this connects to your vent. And then down this wire, you have these little electrodes that we'll see will help us measure and pick up the diaphragmatic activity. And we also have an outlet for feeding syringes so that this tube actually could be used as a feeding tube. This is a more technical view of the EDI catheter. And as you can see, it is meant to be exactly like a feeding catheter, except that it has this wire inside with electrodes. What's the idea? The idea is that you insert this catheter like a feeding tube, and the electrodes are supposed to hug the diaphragm and pick up electric activity from the diaphragm, and that's going to be called our EDI signal. And that EDI signal is what's going to be transmitted back to the ventilator. By the way, you have to interrupt me if there's any questions, okay?
Yeah, definitely. Thank you.
Okay. So this is another way of looking at this. This is another diagram from a textbook on mechanical ventilation. And if we're just focusing on this area here, you're really noticing how we're trying to perform ventilation using neuronal activity measured at the level of the diaphragm. So the respiratory centers in the brainstem send the message via the phrenic nerve for spontaneous breathing, right? The electrodes in the EDI catheter detect the electrical activity in the diaphragm and transmit the signal to the ventilator. Now, the ventilator assists the spontaneous breath of the patient by delivering pressure that is directly and linearly proportional to the EDI. So what the ventilator is going to do is, based on the information that's provided by the patient through the diaphragmatic activity, will deliver a certain peak inspiratory pressure, and that will be proportional to the patient's effort. The inspiration is maintained until the electrical activity decreases by, I would say 40 to 70%. That's not completely accurate, of the peak pressure generated, and then the breath is terminated. So if you know about conventional modes of ventilation, there's usually flow cycling or something like that to stop the inhalation. Well, in this case, the baby, based on the electrical activity of the diaphragm, will automatically decide when to terminate the breath. We'll talk about that more. So if we're going back as to how this is supposed to happen, right now, our current technology measures airway pressure, flow of volume at the level of the ET tube and sends that to the ventilator for information. What NAVA is trying to leverage here is trying to really move up into the ventilatory sort of cycle and really work higher up, closer to the central nervous system, and try to have a more neurally activated mode of ventilation. So what are normal EDI for neonates? There's a lot of data that is out there. And this is one of the tables that was published by Dr. Beck on some of the data that was published looking at these different values based on whether you're using invasive, non-invasive, or no assist. The bottom line is, for what I'm using is that an EDI peak, which is that the maximal activity of the diaphragm during inspiration should be between 5 and 15 microvolts, and the EDI min at the end of expiration should be less than 5. So what are some of the terms that we've mentioned so far and that we need to be familiar with? So NAVA, obviously we mentioned, neurally adjusted ventilatory assist. The EDI is the electromyogram of the diaphragm. So far, all that is clear. The EDI peak represents the neural inspiratory effort and is responsible for the size and the duration of the breath. So that's the maximal activity of the diaphragm, technically at the end of inspiration. EDI min, the minimal EDI, is the spontaneous tonic activity of the diaphragm, which really happens at the end of exhalation, right? And finally, we have an EDI trigger, which is the minimal, usually set by the clinician, right? And it's the minimal increase in electrical activity that will let the vent know to interpret as a spontaneous breath from the patient. So far, so good?
Yes. Sorry,
okay.
I have you mute.
No worries. So what is the freaking NAVA level, right? I mean, that's something that's everybody is struggling with, and I was really much having issues with when I started using NAVA. So first of all, let's go back to NIMV and see what we know very well, because that's the way I thought about it, right? I thought exactly like you, and I said, you know, I know how to do an IMV, I know how to do conventional ventilation. So my brain was trying to really transpose some of that knowledge onto NAVA. So on a conventional ventilator, on an IMV, you would have your PEEP, you would have your respiratory rate, and you would have your PIP, right? How much pressure above PEEP you would provide. The NAVA level is actually a factor. And it's a factor that converts the EDI signal into a PIP. The units for the NAVA level are centimeter of water per microvolt. And the EDI is multiplied by this NAVA level to determine the PIP each breath. So this is something that's very important to understand, that you set the NAVA level, which is a factor, and this will basically change the PIP almost breath to breath based on the baby's activity. The peak pressure is determined on an ongoing basis every 60 milliseconds and continues to increase as long as the instantaneous EDI increases, as determined by this formula. So this is how the NAVA level comes into play. So your peak pressure, the vent has to find out what PIP should I deliver, and it's going to use the NAVA level, which you're going to set, Dr. Spencer, times the EDI peak minus min. So it will make this subtraction, and then it will add the PEEP. Okay. So what's important to realize here is that the NAVA level you set on the vent, the PEEP is what you set, the EDI is something that is determined by the patient, okay? So this is a patient that we have in our unit right now. And this is sort of how the Servo U looks like when you're putting up all the different graphs. Mm-hmm. So here at the bottom, you can see PEEP is 9, NAVA level is 2, and and that's really it. That's all you need to know. That's all the settings we need. And if we were trying to calculate what is the PIP, so we use the equation that we just talked about. The peak pressure in this case will be the NAVA level, which is 2 for this patient. We're looking here. Can you see my mouse?
Yeah, I can.
Yeah, okay. So here you have your EDI peak, which is 8.9, and then your EDI min, which is 1.5. So you would do 8.9 minus 1.5 plus the PEEP, which in this case is right here, 9. So that's 2 times 7.4 plus 9, 14.8 plus 9, 23.8, about 24 centimeters of water for the peak pressure. And if you look, the vent gives you back a lot of information, but you see here at the top where it measures the peak pressure.
Yeah.
This is 24. So this is the same PIP you used to set on an NIMV. So this is a non-invasive mode of ventilation that we're using on this patient. So in old NIMV, you would have set the rate, you would have set the PIP. The rate is dictated by the baby. Whenever the baby takes a breath, the vent will assist. The PIP is determined by this NAVA level as a proportion of the electrical activity of the child. And you can calculate that, obviously. But this, obviously, these EDI peaks and mins, it's kind of easy to do right now because I've frozen the screen. But as you can see from the line, it moves up and down, and the vent does continuous calculations to make sure that it's always adequate when it comes to providing the right type of peak pressure. So yeah, so this is what I was trying to hint at. So we talked about that already, that the breath stops on inspiration until the electrical activity decreases by 40 to 70%, which is again initiated by the baby, and then the breath is terminated. So how do we set up a NAVA? I think for me, I've learned ventilators very well by just learning how to set them up. So number one, you have the catheter. So the catheter placement starts by picking the right size. And to pick the right size, you kind of need to know both your patient's height and weight. And then you can make an assessment as to which catheter size to use, 6 French versus 8 French. The measurement is basically the same you would use as when you're putting an NG tube, right? You would go from nose to ear down to the bottom of the xiphoid process, and you would pick that measurement. Then once you have that measurement, right, there's these tables that are available. And again, I can share with you this presentation. You have, if you're putting it nasally, if you're putting it orally, and then it gives you the calculation. Now, if you have servo use, you can actually enter all this information in the vent, and it will calculate for you how deep the catheter should be. Oh. Now, yeah. Now it doesn't really matter. So your nurses know how to assess, obviously, how deep to put the catheter, but the bottom line is not going to rely on a measurement alone. So because at the end of the day, your measurement doesn't matter. You really want these electrodes to be right there around the lower esophageal sphincter, right where the diaphragm is, because if you don't have your electrodes there to pick up the electrical activity of the diaphragm, your vent is not going to work properly. So what we do is that we can look on the vent at the EDI catheter positioning. This is the screen on the servo U. And here you can see on the left-hand side, you have your catheter. It's the white bar, and the electrodes are represented by these dark dots, okay? And the beautiful thing about the servo U's is that they will highlight which electrodes are picking up activity. And in this case, you see my electrodes here are the middle 5 that are picking up the activity. Now, what is very critical for you to understand is that joined, you want to make sure you have some electrodes above and some electrodes below that don't really pick up any activity, because it's the only way for you to know that you have some electrodes that are past the diaphragm and some electrodes that are above. If some electrodes are only at the top, you may be missing more muscle up there. If all the electrodes are firing at the bottom, you may be missing more diaphragm down there. So let's look at this video quickly that shows you how to set up the EDI catheter. So this is similar to what I've just shown you. And then this video is kind of nice because it will actually show you what it looks like if you've gone too deep or too high. That's also a good feature. If you press I on these monitors, you will have a lot of information about 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 NAVA and about how to use these different screens. So,
sorry to interrupt,
yeah.
but does that mean that you don't need to confirm position with imaging?
That's correct.
Oh, wow.
So this is an example of how the EDI catheter is too high up, right? So you see 3 electrodes at the top are firing, and all the other electrodes are probably in the stomach. So you're probably missing some of the diaphragm, and you want to make sure that's how what we were talking about, making sure that you have some electrodes above and below that are not activated. Okay, let's talk about then settings, right? As clinicians, we want to know what settings do I pick. So this is how you set up your NAVA, right? You go into modes, and then you pick NAVA, and this screen pops up. And we'll go over every item on the screen. You have here your FiO2, that's an easy one. The PEEP, I don't think you guys need to know too much about PEEP, you know already a lot. And then here we have PC, which are your backup settings. So what am I don't know, I forgot what this video was showing us. Hold on. Okay, doesn't matter. Apnea time, let's see. I'm sorry, 1 second. Oh, this is, so one of the settings you can set is the apnea time, right? So that means how long am I going to tell the vent that they can tolerate the baby not making an effort? And those could be set theoretically at either 2 seconds, 5 seconds, 7 seconds, or 10 seconds. I do not recommend using 2 seconds. The reason is, as you may have guessed, the shorter your apnea time, the more the vent will trigger the backup ventilation system. Because you're saying, hey, if the baby doesn't breathe for 2 seconds, then the baby is apneic, you have to kick in regular NIMV or regular conventional ventilation. So most of the time, we tend to start off around 7 seconds. And depending on what you're trying to do, you can either go to 5 or go to 10. So for example, if you're wanting to see if the baby is actually getting close to being weaned off non-invasive ventilation, I would probably go to 10 seconds, right? And see, okay, let's see if the baby triggers the vent very frequently when I put my apnea time at 10 seconds. And if the baby doesn't trigger the backup ventilation, then I feel like the baby is breathing very effectively. If I feel like a baby needs more help, I will say, all right, let's give this baby a bit more help and trigger backup ventilation at 5 seconds. Now you have to make sure too that the backup ventilation settings that you're putting on the vent are not too generous because you don't want to hyperventilate the infant. So when we go back on this picture, we see here the bottom 3 squares are your backup ventilation. And this is the backup respiratory rate. So that's here, they set it as 15. You have your backup PC above PEEP, which is your PIP, and your backup I time. And this here is your apnea time. I think this is for an adult, obviously. So they set it at 20 seconds, but I mean, I wouldn't set it to 20 seconds, as I said, between 5, 7, or 10 seconds. Right. So the backup ventilation obviously just means that if something is going on with the baby goes apneic, then that triggers. Or if there's an issue with the catheter, let's say you disconnect the catheter accidentally and the vent no longer picks up a measurement, the vent will automatically start going back into this backup ventilation mode, which will follow the respiratory rate you've set and the peak pressures you've set as well. Now, what is the EDI trigger? So we know about triggers when we're using conventional ventilation, where we have our sensors at the ET tube and we put the flow sensors, we can put our trigger. The EDI trigger is the increase in the EDI that needs to occur for the ventilator to think, okay, this is a baby trying to take a breath. The key is do not set the EDI trigger too low, because then when the baby is either not taking an effective breath, or if the vent picks up any random activity, then you may have the vent not realizing that the baby is apneic. So usually a start would be 0.5 microvolts. I have rarely had to change that setting. So let's take a look at a little bit as to why this is important. So this is a video on the EDI trigger.
0.2 microvolts means that very small EDI signals will be recognized as spontaneous respiratory activity. It appears that this neonate has some spontaneous respiratory effort, but these breaths are unlikely to be clinically effective because they are too small. The low EDI trigger is preventing the neonate from going into backup at times. The spontaneous breaths are usually insufficient to support the neonate, and therefore frequent episodes of desaturation and bradycardia may occur. The neonate may benefit clinically from more backup support. If the Edi trigger is increased to 0.5 microvolts, it will be less sensitive to changes in the Edi. Now the Edi signal has to increase at least 0.5 microvolts to be recognized as a spontaneous breath. Small changes in Edi activity are now ignored and the neonate remains in backup. The neonate will then receive adequate ventilatory support until a stronger Edi signal is available and effective NAVA ventilation can resume. When the Edi signal increases appropriately, backup ventilation ceases and NAVA will resume as shown in this.
Okay. The last thing we need to talk about are alarm limits. Don't forget to set them appropriately, but you should, a bit like volume guaranteed, you should pay special attention to peak pressure. And the reason being that you do not want to allow the vent to reach really unreasonable peak pressures when delivering NAVA ventilation. So obviously the big question is, how do we choose the appropriate NAVA level? Where do I start? How much do I go up? How much do I go down? And that's the last, and I guess the most important setting that we have to pick on these vents. So what are the physiologic implications of choosing the right NAVA, the right NAVA level? So remember that the NAVA level controls the level of ventilatory support. As the NAVA level increases, the patient can either maintain the Edi signal at the current level, resulting in increased delivered inspiratory pressure, or the patient can decrease the Edi signal and say, you know what, you're doing all the work, I'm good, just keep doing what you're doing. Systematically increasing the NAVA level will create something called unloading on the respiratory muscle and is followed by an initial increase in the inspiratory pressure, mean airway pressure, and tidal volume while the Edi remains constant. So what do we mean by that? This is the phenomenon of unloading. If this little kid is trying to pull the box and has to put in a certain amount of effort to do so, and me in the background is pushing while the other kid is pulling, the work being done by the child is minimal. And another way of understanding what NAVA is by understanding the assisted sort of pull-ups that you have probably seen at the gym, right? So in this video, you see this guy just trying to do chin-ups, but he has underneath his knee a little stool, and these weights are basically helping him to reach up. If we're setting the weights to nothing, then the patient has to do all the work. If I'm setting these weights to the maximum, then the person doesn't have to do any work because the weights are just lifting you up by themselves. And so the key is to find this right balance between enough support that your work of breathing is effective, but not too much support that you're really not doing any work. So what we're looking for is something that we call in NAVA ventilation as the break point. And the break point is the point in the settings where the peak pressure no longer increases and the Edi peaks starts to decrease. So let's look at this, for example. Number one, you can see at the bottom, we have our NAVA level. This is a good graph because it also shows you some of the ranges of what NAVA levels can be. The lowest here is 0.1. I wouldn't call that the lowest level on NAVA. I would say 0.5 is the lowest you should go on NAVA. You should never be below 0.5. And the highest here is 3. Again, I think you can go to 3.5, but usually the NAVA level never goes beyond this range, 0.5 to 3.5. And here you can see that we start at 0.1. And at the bottom with the little square, we have our Edi peak, the maximal activity of the diaphragm. And then at the top, we have our peak inspiratory pressure. And we see that as I go from 0.1 to 0.5, my Edi peaks are pretty much staying the same. And then I go to NAVA level of 1, and suddenly my peak inspiratory pressure goes really high. And my Edi peaks are increasing as well. But beyond this point, if I continue increasing my NAVA level to let's say 1.5, then my peak inspiratory pressure doesn't really move anymore, but now my EDI starts decreasing. And now we're reaching the point where if you were doing these assisted pull-ups, now I'm helping the baby too much, okay? And so this is what would be determined as the break point. Now, for my purposes, again, I'm going to share with you what my experience of using NAVA has taught me. I usually start a patient at around 1.5. 1.5 to 2 is a good place to start, and we'll talk about what to do after that. So this is another video, and it shows you very nicely when you reach the break point, okay? And the idea here is that what they're going to do and what they're recommending is that you start with the NAVA level as low as possible, and you slightly go up to recreate the graph that I just showed you.
Starting at a NAVA level of 0.5 centimeters of water per microvolt and increasing in a stepwise fashion every few minutes until the average peak pressure remains stable as the NAVA number increases. It is important not to react to single peak pressures, but to look at average ranges. At a NAVA level of 0.5, this neonate has EDI peaks of 10 to 20 microvolts, producing average peak pressures of 10 to 15 centimeters of water. When the NAVA level is increased to 1, the EDI peaks remain 10 to 20 microvolts, but the average peak pressure increases to 15 to 20 centimeters of water. At the NAVA level of 1.5, EDI peaks now decrease to 4 to 9 microvolts, and average peak pressure range from 15 to 20 centimeters of water. As the NAVA level increases to 2, EDI peaks continue to fall and now are mostly less than 5 microvolts, but average peak pressures remain unchanged at 15 to 20 centimeters of water. This is seen again when the NAVA level is increased to 2.5. EDI peaks are further diminished, and peak pressures again remain unchanged. Note the need for occasional large sigh or recruiting breath. When reviewing the data for this neonate, the NAVA level should be set at 1 to adequately unload this neonate's work of breathing. This should also be evident clinically with decreased retractions and respiratory rate as the neonate's work of breathing improves.
So, right, I mean, this is something that makes sense, and that could be an easy pitfall. I think what I see most of the time is that people seem to be happy when the EDIs are low, because it means the baby is not having to do a lot of work. And that could be a big issue. You really want to try to maintain your EDI peaks, as we've said before, between 10 to 15, and you want your EDI mins to remain below 5. And if you are ventilating a baby and your EDI peaks are 7, then you're overventilating and you need to back up. I'm going to skip the idea of NAVA preview for now.
Arrows.
Oh. So then the question becomes, why should we use NAVA, right? Why am I complicating my life with NAVA when I used to ventilate patients very well? And what's the idea here? I think the number one aspect of NAVA that is attractive is the fact that it provides synchronized ventilation in both invasive and non-invasive modes. And that's something that, especially in the non-invasive modes, we've not had in the past. The other thing is that it provides proportional delivery of PIP based on neural inspiratory drive. And that's something that, a bit like volume guaranteed, has been shown to be extremely beneficial for neonates. The third point is that it provides more patient control, meaning the baby determines the breath rate, the eye time, the peak pressure, and the breath termination. Again, all more physiologic and better for the infant. Finally, I think that's another aspect of NAVA that we should talk about is the exceptional ability that you have to monitor your patient. So it gives you the ability to monitor neural respiratory drive and neural breathing pattern via the EDI waveform with or without NAVA. So if you go on your servo use and you go into the trends and logs section, you can actually reach this set of graphs. And here you have 3 hours worth of data. You can actually click on this and you will have 12 hours, 24, up to 72 hours. And you can actually trend your EDI's means and peaks. And that means that I can review the work of breathing of a patient for the past 24 hours. What we've done in our unit is that I've even left on NAVA catheters while the baby was being transitioned from something like NAVA to CPAP, because I can actually monitor while I'm doing this wean whether my baby's EDI start jumping or continue to stay stable. It used to be that before NAVA, we would have to make the switch, wait a little bit, get a gas. Right now, you get this in real time where you measure your work of breathing effectively through the EDI, and you have that information in real time. It shows up here, and you can review it here for the past 3 to 72 hours. The other thing you can see on these trends, and I'm sorry that the pictures are not straight. It's just like we try, but we don't do such a good job. But you can actually see the percentage of time that your baby went into backup. That's very, very helpful. If you're setting NAVA and you're on pretty high settings, and then you find that your baby goes into backup very, very frequently, then that means that there's something wrong and that you should investigate why this is happening. So let's talk a little bit about the contraindications, because there are some babies that are not going to be allowed to be placed on NAVA. Any baby with a brain anomaly or medications that are causing apnea should not be placed on NAVA, right? If we remember, that's what we started the presentation with. NAVA stands for neurally adjusted ventilatory assistance. And it's an assistance. If you're not breathing, then NAVA is no good for you. If you have any anomaly when it comes to your esophagus, if you have esophageal atresia, diaphragmatic hernia, even though some people are starting to study whether we could use NAVA in diaphragmatic hernia, but personally, I would stay away. Any phrenic nerve injury, babies who had cardiac surgery or who have any congenital phrenic nerve injury, then are not good candidates for NAVA. Any congenital myopathy, if your electrical conduction and your nerves are not functioning properly, NAVA is not for you. And then finally, MRI scanning. Do not send a baby with NAVA and a NAVA catheter to the MRI machine. Yeah, this is going to be a recipe for disaster. So what is some of the evidence that we have right now that it is beneficial or that we could use it in neonates? So this is a study from 2017 out of the University of California in San Diego. And basically they used NAVA catheters in 81 patients, actually in 14 patients, but for 81 patient days. And what we see on this graph is that comparing to an IMV, the NIV-NAVA produced significant reduction in PIP, FiO2, the frequency of desaturation, the length of the desaturations, and the caretaker movements. So that's not really surprising. This is another study from Japan comparing preterm neonates on conventional or high frequency ventilation and those on NAVA. Again, you always have to pay attention whether we're measuring NAVA invasively or non-invasively. But in this case, you can look at, it was a small study, obviously, so the significance is not there, but the total duration of ventilation days was lower in the babies on NAVA. The rates of BPD were about like 20% lower. And the discharge with home oxygen was also lower. Looking at the days on sedation and requiring other medications, those were much lower in babies with NAVA. And it makes sense. If the baby doesn't have to really fight the vent and is in sync with its ventilator, then it's much less likely that we need to sedate or really give any medications to the baby. This is 2019 data from South Korea looking at the extubation failure in preterm infants that were either extubated to CPAP or to NIV-NAVA. And you can see that babies who were extubated to NIV-NAVA actually had much lower extubation failure rate. This is from the same study. And you can see that the extubation failure rate was 6.3% versus 37.5%. And those were significant despite the fact that it was a small study. This is another study out of Toledo looking at babies that are less than 1,500 grams. And basically what happened is that their unit switched, no, not switched, but their unit actually introduced NAVA, and they allowed clinicians to transition babies from SIMV to NAVA. And when that happened, they monitored a bunch of parameters. And you can see here that when it comes to PIP, mean airway pressure, pH, PCO2, and so on, those were much lower in babies on NAVA. This is the meta-analysis looking at a bunch of other studies, and it's comparison. It's kind of a nice table. This was published in 2020. And here you have on the third column, the type of comparison that they ran. These were all on non-invasive. And what I'm trying to show here is that it's not a slam dunk, right? It's not like NAVA is superior to all the other modes. But there is in many studies, it has shown to be extremely beneficial, especially when it comes to degrees of complication, being synchronized, the amount of oxygen requirement. But there's still a lot of studies that are not seeing much difference. And I think this, in my opinion, points to the fact that you have to pick the babies that will tolerate NAVA best and that you think will benefit the most. It is not something where you should suddenly switch all the way you're ventilating babies from conventional to NAVA. I think it adds one more tool in your arsenal, and you'll be able to, the babies that will not tolerate conventional ventilation, you may see that they do very well on NAVA. So in summary, NAVA is evidence-based, meaning if you were to use it in neonates, you would have evidence supporting your decision. It relies on neural activation of the diaphragm to provide proportional respiratory assistance. It can be provided in both invasive modes and non-invasive modes. NIV-NAVA, in my opinion, is very innovative in a way that it allows you to actually provide synchronized ventilation to patients when they're after extubation. And the last point is that NAVA really should be also seen as a way to monitor the patient's work of breathing. I think the same way that the pulse oximetry was revolutionary in the way it allowed us to monitor patients' O2 sat, I think NAVA is allowing us to monitor the work of breathing of these infants in a way that has not been done before. If you guys are interested, we actually spoke to the creators of NAVA, Dr. Jennifer Beck and Dr. Christer Sindaby, on our podcast, and they talked to us a little bit about what their vision was for NAVA and what they think it can do in neonates. Questions?